My name is Sandro Galea. I serve as Dean of the WashU School of Public Health. Welcome to Public Health Ideas. These are conversations that aim to highlight work that advances the science of health. This, in particular, is part of a series of conversations we are having about current changes to the policy landscape. The goal is to have non-partisan science-based conversations, to keep an open mind about potential policy change, even to welcome potential change for the better, but to be analytic about how proposed changes may affect the health of populations. Today, I have the privilege of speaking with Professor Phil Marotta. Dr. Marotta is an assistant professor at the Brown School of Social Work at WashU with a secondary appointment in the School of Public Health. He studies the effect of criminal justice system on health disparities. Welcome, Phil.
Thank you so much.
So I want to talk a little bit about the current changes being discussed and some implemented, about criminalization versus treatment of illicit drug use and the shifting emphasis on punitive responses to substance use rather than harm reduction that has been dominant in the past few years. Yeah. So let's take a step back. Lead us through, what do we mean by harm reduction? How do you compare harm reduction to more, say, punitive approaches to illicit substance use?
Absolutely. That's a good foundation to start with. So harm reduction is simply defined as it sounds. It's defined as reducing the harms associated with engagement in certain behaviors. This can be drug use, can be food, it could be obesity prevention. But in the context of our discussion, it's focused specifically on reducing the harms associated with drug use. Within that purview, there's a core principle that governs harm reduction, and that is one individual should have control over their health decision-making. And not everybody is ready to change at the same time. Some people have more resources to be able to engage in change. Others do not. And so harm reduction offers life-saving measures to people who are not perhaps at that stage where they could stop. A more controversial understanding of harm reduction, one that is part of harm reduction, and as we understand it, is that regardless of whether or not somebody is willing to change, their life is worth maintaining. And so their access to naloxone and other harm reduction strategies should be preserved, whether or not somebody is at a place where they should be willing to change or not. There's many justifications for this. There's a moral one, there is a financial and economic one, but then there's also a public health mission, and that is to offer everybody the building blocks that are needed for health. And harm reduction simply offers an opportunity for somebody to prolong their life until they're able to reach that ultimate destination.
That's a great description. So I will point out a bit parenthetically that Ernie Drucker, one of the fathers of harm reduction in this country, recently passed away. He was an old friend and mentor. So it's actually, in some respects, talking about harm reduction now, both reminds me of him and honors him.
It's funny that you mentioned that, because he was my mentor as well, and a very dear friend of mine, and also was one of the founders of Harm Reduction Journal, the main venue for disseminating this research, for which I'm an editor-in-chief of. And so much of what I'm pursuing is started with Ernie and others in the 1990s. So would you like me to articulate a little bit about punitive approaches or how this relates to punitive? Sure. So this stands in contrast to punitive approaches. And we can think about punitive approaches to drug use has really been adopted in the mid-1900s. Up until that point, we did not have a regulatory framework or a prohibition framework, except for what had started in the early 1900s with our approach to alcohol and some of the initial regulatory efforts to curtail opium. So this is a relatively new endeavor to be restricting people's substance use. Throughout much of history, people were able to use substances pretty openly. So we have adopted largely the British model, and we have pursued criminalization alongside of the British as well. So we adopted the war on drugs in the 1970s about the same time as the British did. Harm reduction, the more money we were putting into criminalization, rates of drug use were just continuing to go up. And so alongside of this movement towards criminalizing drugs, which started in the 70s with ramping up punishment, search and seizure laws being implemented, various erosion of due process rights, drug use continued to go up. We did not see a decline respective to all of this money being put into the war on drugs. So people started to step back, and the movement around harm reduction emerged out of the HIV movement, as well as out of the comprehensive sexual education movement. But in the 90s, there was an understanding that syringes and use of syringes were contributing to HIV. And this was the initial recognition of harm reduction as an alternative. However, at that time, syringes were firmly prohibited. They were illegal to be possessed outside of the instruction of the medical system. So there was an at odds that was established with the harm reduction movement and criminalization that really stood in the way of some of our initial early interventions to curtail the HIV epidemic. So harm reduction offers an alternative set of approaches, one that focuses on individual choice and determination, and a movement away from traditional punitive approaches, mainly arrest and incarceration. However, we still have a whole compulsory treatment model that I would like to talk a little bit about, because it's easy to think we're moving towards decriminalization, but in many ways we are replacing one form of enforcement with another in the United States, particularly through the realm of forcing people into treatment.
I want to get to that in a second.
Sure.
Before we do that, let me ask you a question, because I think sometimes in the public conversation there is a notion that what we consider to be illicit drugs is fixed. But in fact, the story of what we decide to call illicit and what we don't is pretty checkered and in some respects idiosyncratic. Can you just comment on that just for a second?
Oh, absolutely. I mean, opiates is a great example of this. I mean, opiates are illicit and licit. We use opiates with the instruction of a medical doctor, and then it's okay. But when one has pain and their doctor is not allowing them access to those critical medications, they may turn to the illicit market to just fix the same need, to just solve the same need. So harm reduction criticizes that approach by arguing that we're all using drugs to address the same need, whether it's licit or illicit drug use.
Yeah. Let me jump to, let's stay on this more theoretical approach for a second. Let's talk a little bit about the harm reduction model for substance use and the punitive approach or abstinence models, and guide us through the data, the merits of each approach, and talk a little bit more about some of the nuances that you were introducing a second ago.
Sure. So the data for many harm reduction strategies is well established. There are some newer harm reduction strategies that have been developed where we are still accumulating data and researching those strategies. So I will start with the most well-established data in support of harm reduction, and that medication for opioid use disorders, syringe exchange, and naloxone really stand, and condom use and many of the sexual health interventions have been studied so much that they don't need to be evaluated in the lab anymore. They're no longer necessary to be effectiveness trials, so to speak. And now we're moving into more implementation trials of those studies. So we have decades of research, for example, that supports the notion that if you access sterile syringes, every time one injects, the likelihood of HIV or acquisition of hepatitis C drops dramatically. The same thing for naloxone. We know that if we get naloxone into the community at such a rate where people have it when somebody overdoses and can administer it as a layperson or as a part of that social network, that will increase survival. We also know that those interventions are much more cost effective than housing somebody and removing them from the population and putting them into a prison or into a compulsory treatment center. We know that many of these harm reduction approaches are less costly economically. However, we also know that harm reduction, and this is something that I think we're seeing more and more with stories like Oregon and what happened in San Francisco, that harm reduction is a mirror to society's problems. Because when you open the doors and you no longer have things happening in the dark, you see more of the problems that are happening already. So I can tell you an example of this is that if you go into an open air community and you arrest everybody from that, you will remove that problem very fast from that community. But the reverberating effects of that choice, of that policy response, will be felt later because people will be afraid of the police, they will rush through their injections, and be much more likely to die. And we have tons of evidence on this. We've had studies that have shown that open air drug enforcement, it may solve a problem immediately, but people are going to go to other communities, inject more alone, and not be engaged with the medical system, thereby much more greater risk of death. So it's one of those situations where you have to look at the whole context within which these problems are happening. Another example of this is that there's modest evidence that deterrence works. So if you look across numerous criminological studies, whether it be robbery, whether it be murder, whether it be a variety of these, deterrence really, especially in our justice system where there's not swift punishment, where there's extensive due process rights, our deterrence effects are less than saying, oh, well, you're going to have this definite punishment that's going to happen right away. Instead, people respond generally better to incentives. People tend to look not to what would be the punishment for me doing this, but what would be the added benefit to my life if I operated in the health promoting way, or if I stopped using. And this has been researched quite a bit, that, for example, if you offer people financial incentives and economic incentives, they are more willing to change than in their mind being offered punishment for their actions. Humans respond to incentives broadly better, broadly more responsively to either financial, social, economic incentives than they do the notion that they're going to have a legal preventing them to work for the rest of their life, having a legal record, for example.
Now, we're recording this in the middle of 2025, and we're at a moment where there's some, I think, real reckoning with places which were seen as having gone wrong. Well, Portland, Oregon is a perfect example. So what happened in a place like Portland? Guide us through how did the balance between harm reduction, punitive approaches, criminalization, non-criminalization, how did that go wrong insofar as one could agree that it went wrong at some level?
Absolutely. Well, you're speaking about Measure 110, and let's for a moment just define what Measure 110 is. So Measure 110 is a set of strategies to introduce treatment instead of incarceration. So what happened under Measure 110 was instead of being arrested for small possession or even up to moderate possession of hard drugs, and by hard drugs we mean cocaine, stimulant, variety, methamphetamine, drugs that are above cannabis, which is already legal in Oregon, you would be fined $100 and then referred to a hotline that would be then required to call and receive a health assessment, and that would be a waiver of that $100 fine if you called this line for a health assessment. So what they found was that fewer than 1% of people called that hotline. To me, that's not surprising. We're seeing other diversion programs fail because of this, because of many reasons. Let's look at one reason. All of the things that happens in the life of somebody who uses drugs between that moment of being arrested and having to call a hotline on your own. This person could be homeless, they could be dealing with violence exposure, they could be not having access to a phone. I mean, all of the issues that raises. I mean, I'm a social worker, so I study and do a lot of work around healthcare access and social determinants of health. And if you just give somebody that could not be more of a cold referral. And so what we know in the research that works is warm handoffs. So I could get into what could have been done better in a moment, but that's a cold handoff. That's the opposite of a warm handoff. So that already kind of set up the stage for failure. Also, and I think this is a recurring problem across these efforts, both in the US, but in other countries, also in New York State. New York City has dealt with this. And that is this idea of building up the capacity to handle the mirror of what that's going to reveal, right? So if you say, come to our city, we're going to be more welcoming, we're going to be more open about drug use so that we can get you help. Well, you're going to see more problems that way. And there's going to be many more people that may feel comfortable coming out with their problems. And so the reality of that is that we need to make sure that the adequate number of beds, the adequate number of treatment slots, but not only that, the adequate number of employee assistance and social services and all of the necessary dignified care that people need to be able to actually change and do the things that we're hoping to have them do is often not provided. And so this is actually a cycle, a policy cycle that we see happening. The second piece I'll mention with that is too short of a time horizon. As investigators, we always complain, and at least I do, about 5 years is not enough to see changes in many of our studies. Yeah. I mean, how are we going to undo decades-long deindustrialization and massive social problems with a 5-year follow-up, or even just 2? I mean, how long was this? 2-3 years that this was? So it makes sense to me. Politicians are impatient. They want to see these results before next year's election. And so when they see these numbers building and divisive rhetoric from, the White House, it's easy for a politician to be fearful that they're going to lose their political positioning, and they will resort to punitive approaches. Also, punitive approaches are easier. I don't know, parenting, people talk about this, that being harsher can be quicker, easier, and simpler than sticking with somebody on the day-to-day effort that is really needed. And so sometimes I think people see it as an easy option. They see this as it's low-hanging fruit for politicians. What are the numbers? How do we get our arrest numbers up? Those are a whole lot easier. So if you look at overdose rates now, they're going down. And this has been, we have been working for years to get it to that point. But if we had cut the spigot off of funding after 2 or 3 years, we would have never made these gains. They need a much wider time horizon. And then the political press, the press that it was getting also played a big role in the unraveling. And this has been the case in many other places as well, where, news sources portray it in a certain light, and that erodes the momentum that some of these initiatives are getting. Yeah.
Let's go national now. So we'll talk about Portland.
Absolutely.
And, to talk us through, start from the past few years. What's the national climate been like around harm reduction, balanced with, as we said, with punitive approaches?
Yeah.
And where are we at today? Where are we at with a new administration? Where is that headed?
So much of it to be seen. However, let's look at 5 years. We have seen more growth of harm reduction in the last 5 years than the last 30 years. Harm reduction has become mainstream. It's become embedded in the population's understanding of health. So, for example, Biden in 2021 included harm reduction for the first time as a pillar of the overdose prevention strategy. This was a big accomplishment. The downstream effects of that is now SAMHSA has a landing page on harm reduction. NIH has a landing page on harm reduction. If you search harm reduction, you are not just getting NGO advocate definitions of it. You now have an official government position on harm reduction. That should be a win. People should step back and really absorb that and it's not been undone in the current administration. Before meeting with you today, I was looking at what has stayed on the websites and the government repositories. And I will say overdose harm reduction is largely undisturbed. Now we need to think about harm reduction as existing within 3 movements: comprehensive sex ed, HIV and sexual health, and overdose prevention. These are the 3 major. In the other 2, it's taking a huge hit. I came here to talk with you today about drug use, but we know that these are intertwined because of injection drug use pathways, because people engage in sex while they're using drugs. So we know that these are intertwined risk factors. So what we are seeing at the federal level are really, since the latest administration took office, is a reduction in sexual health funding, but not as much in the overdose prevention, but it is still getting hit. We are seeing reductions across the board, but we're seeing eliminations and consolidations of funding opportunities, for example, in the HIV space. We're not really seeing that in the substance use space yet. So for example, NOFOs, Notice of Funding Opportunities for investigator research, or for example, community-based service provisions. CDC was issuing tons of grants. Those are still in place for overdose prevention. I'm still funded by 2 SAMHSA grants that were related to overdose. However, if it has to do with intersectional stigma, substance use, and HIV, we are seeing quite a bit of changing and rearranging happening in the government funding space. Now, let me just say one other piece here. The addiction institutes, we have 3 kind of behavioral health NIH institutes. We have NIAAA, NIDA, and NIMH. They're slated to be consolidated. That is going to have profound effects for how we understand drug use, because over the last several years, people have been advocating for, yes, there needs to be a joint approach in services, but we need to be researching substance use specifically. And if we don't have its own institute, what is that going to mean for earmarked funding and for things that are going to be specifically designated to address the opioid epidemic? So a lot of uncertainty at the national level. As for policies around harm reduction, there is a big rolling back of the emphasis on treatment, even from Trump's first term. So Trump's first term, there was a shifting away from the criminal justice system and more towards treatment in the opioid prevention space. So that was the CARES Act. There was all kinds of funding that ramped up for harm reduction. But we are seeing a rolling back of his own policies, because the Biden administration mainly just continued on the funding that was happening prior. There was not any major breakthrough, except for including harm reduction as the as the main strategy. We did not see a substantial amount of changing or reorganization. So, I do think that we're going to be seeing a lot of opportunities get closed. unfortunately, for substance use, but not as much as infectious disease prevention side of harm reduction.
Yeah.
That's getting hit the hardest.
Let me shift tack for a second. Everything we've talked about has been about demand and use.
Yeah.
Let's talk about supply.
Yeah.
So talk us through the evidence on the realism of actually an aggressive approach on importation of drugs from other countries. I mean, this current administration has talked quite a bit. I mean, a lot of it has so far been talk about trying to take a harder line about criminal organizations bringing drugs in the U.S. Where does that fit in with an overall strategy? How does that intersect with some of the more xenophobic elements of the administration's language? But how do we think of that from a responsible public health point of view, aiming to make sure we reduce the harms of substances?
Yeah, I think that, okay, so I have a few answers to that question. I think that's an incredibly important question. I mean, we tend to put much more emphasis on demand reduction. However, for supply reduction, I tend to view countries like I view people. I don't think punishments work to change countries' behavior. I think if we go to, and I also don't think that hammering at our own borders is going to change what countries bring to our borders. I don't think that that's going to have an effect because we have been doing this all through the Bush administration. I mean, this was like the DEA was funded to do this just 10, 20 years ago, and it had zero effect on trying to change. I mean, we had, when Colombia was manufacturing stimulants at the rate that it was during the war on drugs in the 90s, we were way more than we are now. I mean, we had way bigger supply side reduction efforts then, and it made zero impact on what was coming into the United States. In large part because when border control officials stop drugs coming in, it's only the tiniest fraction of what's getting across the border. I mean, there have been numerous studies that have been shown that it's like less than like 1% of the total drugs that come into the United States. So you will have much better, and this is, again, we don't have any evidence for this. So we actually don't have any evidence in favor of supply side strategies such as just dumping money into the DEA or into ICE to try to remove substances from either the border, but what we could be promising, and this has been talked about a lot in the policy circles, are national trade agreements, national agreements working towards reaching deals. And I know that the current administration is big on deals. And so one way that I think would be very effective would be to structure our conversations not around catching the mice that are smuggling drugs into the United States, but much rather focused on reaching incentivized agreements where sending countries can be showing, or countries that are home countries, or however we want to be defining these places of target that, and they're always going to change, by the way. I mean, China is the country of focus now, but it once was Myanmar, and then it was Afghanistan, and then it was, so these countries are always, these supply side countries are always going to be different. And so that's another criticism of that notion that if we focus so much on our borders that we're going to be able to somehow reduce the number of drugs coming into our country. I think if we place an incentivized arrangement with, for example, Mexico on giving them a direct benefit to their country for curtailing these issues at the border, I think we would have much more traction than we would be by putting people in jail. The other thing I would mention too is that the people, and just from a humanistic standpoint here, the people that we are often catching as drug smugglers are often people addicted to, and struggling with drugs themselves. And so I am advocating for the well-being and lives of all people who use drugs, and this understanding that people go into these economic circumstances for many, many, many different reasons, right? And so the focus really, in my opinion, should be focused on incentivizing countries to take action before we dump all that money into our law enforcement space, because we don't have a good track record with that. In fact, we've destabilized whole countries to try to achieve those goals. So like we've destabilized all of Colombia and other countries, not to a good benefit.
That's a very thoughtful answer. Thank you. I think it's probably fair to say that among all the issues that affect the health of the public, issue of use of substances is perhaps one of the most politically polarizing and divisive. Yeah. It somehow intersects with people's ideology, with pre-held beliefs, with issues of faith. Yeah. How do we catalyze a conversation, national conversation, about reducing the harms of substances the way we're having here nationally, and removing the heat and bringing more light to it?
Yeah. That's a phenomenal question. And I would say that we are already doing this in some ways, but it needs to be amplified. So one way is broadcasting conversations happening on the local level to the national level. I think we too often have national conversations that are being fit to the local context. In reality, rural environments where substances are being used are largely left out of at least the strategies that have been devised so far. Rural communities, for example, are oftentimes not included in these national conversations that are happening. So I think it has to start locally. It also has to start locally by understanding what has been the direct impacts of drug use in local communities specifically. Because when people have conversations with a family whose child they held and died from substance use, the conversation is very different. I mean, I had a NIDA-funded R21 that was an exploratory study to look at rural Missouri and the attitudes of people in rural Missouri, specifically providers, towards harm reduction. And so I went into local communities and we interviewed people from all walks of life in Missouri about how do you define harm reduction? How do you understand drug use in your local community? And the common themes of this was meeting people where they are. But those contexts differ so much across the United States. Yeah. And I will also add that, and helping people understand this in the national conversation, that substances are a symptom, not the actual problem. So, and I always like to kind of debate this question in my classes that I teach, because are substances the cause of public order deteriorating, or is the deterioration of public order the cause of the substance use? And we don't have enough to really understand that question even in our society, yet we speak of drugs like they cause public order to deteriorate. But remember, substances often come after poverty hits. Substances come after violence hits a community and trauma, and then it becomes enmeshed in a bidirectional relationship where one is driving the other into worsening problems. And so to keep in mind that at the national level, I think we always have to be pushing ourselves to say, and I want to see this broadcasted, that what is the substance use a symptom of in the United States? Why are we so sick? Why is the United States the #1 consumer of drugs in the United States? I mean, in the world. And that is not because we're born with some sort of predisposition wanting drugs more than somebody born in another country. It's because something happens across our life course that environmentally, socially disposes us more to use substances than other societies and cultures in the world. And I don't believe that that's because we're not arresting enough people at the border or we're not, holding people to enough account. There's something fundamental about our society that is making us more vulnerable to substances. And I want to see dialogues that answer that question. Because I think if we get at answers to the underlying problems, there'll be less stigma towards the outcome of those problems happening.
A penultimate question. So we actually anticipated this a little bit. We talked about Ernie Drucker and your role as editor of Harm Reduction Journal, which he co-founded. So how do you see the role of that journal, or really any academic journal right now, in moving us forward on this conversation?
Yeah. So that's a wonderful question. I'm just getting comfortable in my new editor role. And I would argue that we need three main areas. One, I want to see more people who are with lived experience, not from the medical community, writing viewpoints and debate pieces that are non-research. So I'm working with the journal to delineate research and non-research related articles and to enhance people writing in, talking more about the issue from a commentary perspective. I think all journals could benefit from doing this more often, delineating, because we are too often confusing research with advocacy. And so journals should do a better job delineating the megaphone for the speaker for either one of those. For you're speaking in this, and I think we need to be platforming more people with direct experience with the issues that journals are writing about. I think too often do we have people submitting to journals that are medical professionals that do not have any direct experience with the lived experiences of these issues. So that's point number one. Point number two is I'm wanting to see more clinical trials done, or I should say experimental studies done, quasi and experimental done, that look at some of these questions in more controlled environments. So we tend to talk about harm reduction, both for and against it, from a very moralistic standpoint, from a very values-driven, I believe this person's life is worth saving, so give them as much harm reduction as possible. That's a values-driven statement. But I do think that we need to see more clinical trials that are testing strategies. What conditions do these work under better? And in order to do that, I think that we need to have more openness from the journals to these types of submissions. The other piece that I think is really crucial, and I think this is going to be the most controversial, and I can't say for sure if we're going to even do this. This is my independent ideas. I want to have a debate column. I want to have the ability for people to write, like I can write to the New York Times a letter to the editor and be like, this reporter said all this stuff that was so wrong. And you can write those responses, but journals have such a narrow way to do it. You have to respond to an article and talk about your complaints. You don't really see this kind of open dialogue. American Journal of Public Health does this well. There's some other journals that do. JAMA has a nice opportunity for this, some viewpoint articles. But I think these articles that are so value-driven, I mean, these journals that are so value-driven, and it's not in the journal that's value-driven, it's the topic. So some of these topics can be very value-oriented, and I think it would be good to have a specific column for, say, what if you created a journal where somebody in stark opposition could write and create an open dialogue where people are debating where to have syringe service programs or where to be. We don't have that kind of balanced debate. And that will draw a lot of controversy, and I'm open to that. I think some people don't want to see those voices platformed, but I think that we have the better voice. And so if we platform those voices and we can provide a voice that responds effectively to that, then you'll have more people won over, because I think that is needed across all of these scientific journals, more of a speaking to the people who are in opposition. I find that journals too often speak to the people that just are going to confirm your beliefs. And we need much more guarded approaches to prevent that. How to do it? I'm still learning. I'm still learning how to do that. I was looking forward to that last part.
So last question. You're in a difficult area. You studying as you do substance use, its consequences.
Yeah.
I think it's difficult always in a moment in time when we're seeing these issues being politicized and polarized. It's challenging. What gives you hope?
It's a great question. The most obvious that should give everybody hope is the dramatic reduction in overdose rates that we're seeing in the United States. I mean, that is the most obvious answer that I would give, because we are finally seeing the effects of some of the work that has been done over the last 10 years. And a lot of that has to do with naloxone being scaled up. A lot of that has to do with more treatment availability. We're studying the reasons for that. A more nuanced reason that gives me hope is that, yes, I work in one of the most difficult areas where death is a common reality, where I read medical examiner reports often, and I read stories that will really test your understanding of humanity. But I remind myself that if people can survive in these conditions and make their lives better and strive and have hope, then I should have hope as well. Because many of the people that you're working with going through these indescribable challenges that it's very hard to even fathom how anybody could make it through them. To see them get through this and live to see another day and to strive to be a dignified human being in this environment, I get a lot of hope out of that.
I think that's a perfect way to end the conversation.
Thank you.
Thank you, Phil.
Thank you so much for having me.
Thank you for everything you do.
Thank you. Thank you so much.